Okay, we are live. I'm just waiting for confirmation for the line. Yep, and we are live. Thank you, guys. Well, good afternoon. This week, I'm back again. This is our second live session of the week. Today, we would like to discuss the colon cancer awareness and colorectal surgery, colonoscopy screening during the COVID pandemic. My name is Kamal Erkan. I'm the chairman of American Surgery Center and United Medical ACO. I have Dr. Sachin Vaid with me from CHRIAS, and I'm going to ask him to introduce himself, and we'll start our presentation. Dr. Vaid.
Hey, good afternoon, Kamal. I'm Sachin Vaid. I'm a colorectal surgeon, and I've been with CHRIAS for now more than 5 years. And we've been performing colonoscopies, colorectal surgeries at our American Surgery Center. We see patients in our offices, and of course, we do the big cancer operations and other robotic and laparoscopic colon surgery at Christiana and St. Francis hospitals. As part of my training, I don't know, I'm sure you probably have seen the website. I did a part of my training in India, then I was in England for a few years, and then finally finished my training, surgical training and colorectal training here in the States, and have been practicing for more than 5 years now.
All right, well, thank you, Dr. Vaid. So I'm gonna go ahead and share my screen, and I have, and this is the topic that you know the most, but we have some questions, and we need some education for us and for our patients. And we'll go back and forth with the questions and the presentation. So now in our group, when I do this, I always have to go through all of our surgeons, but this time I won't do that because everyone that you see on the top part, there are bariatric surgeons, but this time we want to highlight our colorectal surgeon, Dr. Vaid. As he went over his background, you already know what he has done. He's doing cases at Surgery Center, Christiana Hospital, and St. Francis Hospital. Now, today, we wanted to start, March actually is the colon cancer awareness month. So our idea was we want to have two events, one in the beginning and one in the end. Now, although we discussed something that's preventable, treatable, and beatable, it still has its own challenges, and our patients and our society is suffering from this. Estimated cases and number of people who lost their lives due to colon cancer, 147,000, almost 148,000 total cases, and over 54% of these people are over 65. The rest of them are younger. These are with the cases, and then the ones who lost their lives, 68% of this 54% lost their lives, and 25% is between 50 and 64. As you can see, this number and this percentage here, these two are increasing throughout the years, and Dr. Vaid is gonna share those with us. Now, the age group now is not, it's actually less discriminating the ages, so it's going through not just for the elderly, but it is kind of now, it's a threat for the younger people as well. So, and as younger people are at risk, and as this is one of those topics that people are less comfortable, which Dr. Vaid, last time we talked about that a little bit. And after that session, I told a couple of my friends, even after the session, they were still feeling not so comfortable about it. And I think one of the biggest enemy for this process is our comfort level, and also like not understanding the process very well. So I'm going to ask you to start your side of what we are dealing with, what can be done, what is already being done, and then we'll continue with a couple questions.
So as Kamal, as you alluded to it, colon cancer is the second largest, third most common cancer in the States, and the second most common cause of the cancer related death overall in the United States. And that's why we've been talking about colon cancer. That's why it has a month dedicated to us, to it, which is the month of March, because it is a very important cancer to be looked at. It is as you had also mentioned in one of your slides, it's a preventable disease. And the reason why it's a preventable disease is that if we do colonoscopies, we are able to catch the polyps or the lesions, which actually turn into cancer, and we can actually kill it and stop the cancer happening in its tracks, or actually find the cancer at a very, very early stage. The slide in which you showed that about actually there was about 150,000 people had cancer and about 50,000 died, basically 33% mortality. Why is that? That happens if the cancer gets to an advanced stage. If you, I'm sure in my presentation there are slides in which we talk about the stage distribution. Like as the stage of the cancer goes up, the mortality goes up. So, okay, let's talk about this. Cancer, the colon cancer had traditionally been affecting people more than 50, and it's around the age of 65 to 68 that it was that was the commonest age when people got cancer. But over the last few years, actually last 20 years, epidemiological studies are showing that younger and younger people are getting it. And we don't know the reason why that's happening, but we know that obesity is playing a role in it, our lifestyle change, and the diet we are eating also is making a difference in that. A newer concept has come up about the gut microbiome, meaning the bacteria is present inside of our intestine. And any alteration in that bacteria will lead to unintended consequences, be it cancer, be it diverticulitis, be it diabetes, be it depression. We don't know that. But it is the alteration of the gut microbiome, and it's the food we are eating which is probably leading to that. Do you want to move on? Come on. This graph shows that the both the new cases and the number of deaths have gone down since 1975 to 2006. That's great news. But and the only reason why that's happening is because somewhere in the 70s and the 80s, we got really smart with doing our colonoscopies. And that's what kind of prevented, caused a decrease in the cases and the deaths. Let's go on to the next one. And this is the one in which you were talking about that younger people are getting more, like the incidence is going up and also the mortality, because the first columns, 20 to 49, if you see, these are the only two graphs in which both the incidence and the mortality in male or female is going up, whereas in all other age groups, if you see, the graph is going down. Go on, next. So often we get asked this question, what causes colon cancer? And I always say that it is actually a combination of factors happening here. Genes are what you are born with. You cannot alter your genes. So that's one part of the equation. The other part of the equation is your physical activity and the food you eat. That affects your microbiome, and that leads to also can cause effect in which you're going to get, how your gut microbiome is going to be. But the most important thing, and which is highlighted over here, is obesity, diet high in red meat, low in fiber, more alcohol and smoking. These are bad actors. Processed food, bad, very, very bad thing to do. So if you do these kind of, if you eat more red meat, less fiber, more processed food, you are at a very, very high risk of getting colon cancer. And that's the only thing you can actually make a difference, because genes you cannot alter, but you can certainly alter what you eat and what you don't. Go on to the next one. Come on. And this is just a slide of what genes are responsible. And I don't think I need to go over there. It happens on the chromosomal level and the DNA level. We can go further. Yes, so cancer stage and survival. This is what we were actually alluding to in the early part of our discussion, that if we catch cancers early, people live, they survive. Stage 1 has a 5-year survival, meaning if you have 100 people, more than 90% of them will be alive after 5 years in stage 1. Stage 2 also has a high survival, but as it gets to stage 4, which is the distant metastases, the survival goes down to 5 to 10% actually, which is bad. So that's why you want to be able to catch it early by doing something like colonoscopy, because if you do colonoscopy, you're able to not only diagnose it, you can take biopsies, and you can even sometimes treat it while you're doing your colonoscopy. Go on, Jamal. So screening. The problem with colon cancer, like any other cancer, is that they are typically asymptomatic. They don't cause symptoms till there is a problem. And when the problem happens, typically we are kind of late in the game. The best screening test for colon cancer is colonoscopy. I know you had mentioned, Kamal, that people are hesitant about it, people are resistant to do it, but you want to do the test which is going to give you the maximum bang for your buck. You don't want to do a test which is going to be positive, like have a high false positive or a false negative. Colonoscopy has a very, very high true positive and a very low false negative, meaning that you are able to actually find polyps or cancers, and you're able to effectively and efficiently able to diagnose that. Of course, I mean, for colonoscopy, unlike, for example, for mammography, you have to do you have to do a prep, a colon prep, which people are kind of resistant to do, and also that they have to come to the center or to a hospital where they have to get sedation and get the procedure done. And of course, I'm not saying that that's without risks, but the benefits outweigh the risk. If you are seeing in our presentation, what we've shown is that colon cancer has been going down. And the only reason why it has been going down is by us doing more aggressive colonoscopies. Colon cancer is going up in people less than 50 because we've never scoped them. So the only preventable way in which we can actually make a difference is by being aggressive with the colonoscopies. If everything is fine, if they have no polyps, then we don't need to come in less than 10 years. So it's basically once in 7 to 10 year phenomena in which you will be getting colonoscopies. But if you look at the benefits far outweigh the risk. You catch a cancer early, you catch a polyp which never becomes cancer, probably no surgery is needed. And the biggest thing about any colon or rectal surgery is about having a colostomy bag. If everything is caught early.
So, Dr. Vaid, why are we so well, again, why are we so shy about this?
Well, we are not shy about it.
I am. No, I need to get mine done, right? I'm 47 this year. I own a surgery center. I am in healthcare. And
I am 42. I got mine done last year. At our conference, we talked about that, guys, younger people are getting colon cancer, symptoms or no symptoms, get yourself screened. The United States Cancer Prevention Task Force has decreased the age of screening from 50 to 45 for all comers now. So I got mine done last year without any rhyme or reason, because I wanted to be sure that, because I am seeing, of course, I am biased because I see a lot of colon cancer because that's what I do. But having said that, it is out there. And the only way we can prevent that is by doing colonoscopy. So I have to tell you, there's no reason to be shy. The prep is not as violent as it used to be. We use low volume preps these days. The anesthesia is far better. We use propofol these days as opposed to in the olden days, they used to use Versed and fentanyl. It is very safe because you have a separate anesthesia team which is actually monitoring you, unlike in the past, when surgeon used to give the sedation and surgeon used to do the colonoscopy. So it has become safe. The drugs have become safe. The prep is much, much easier than what it used to be. And the benefits are enormous. There is no reason why we need to be shy of this. Yes, I mean,
so I need to schedule mine. I need to schedule mine soon with you then.
I'm sorry?
I need to schedule mine with you.
Absolutely. I'm telling you, it's a psychosocial deterrent that we in our mind feel, oh my God, but it's a very, very safe procedure. Takes about 10, 15 minutes. Once you're out, you're out. You don't even feel a thing, because we've gotten very, very better at this with the sedation and everything. So there's no.
I have one other question while we're going to continue. You have a couple other slides. Do you believe that gluten-free diet helps or hurts in this situation?
I don't think there is any scientific evidence to say that gluten-free diet is beneficial or not in terms of colon cancer. Yes, if you have a gluten insensitivity, like celiac disease, then of course, ingesting gluten is going to cause malabsorption and diarrhea. I don't think we have studies to say that gluten causes colon cancer. But of course, if you have celiac disease, ingesting gluten is going to cause diarrhea, which is going to alter your gut microbiome. Yes, then you have a problem because your microbiome is being altered, which can lead to diverticulitis, colon cancer, and the other stuff. Ulcerative colitis and Crohn's disease also happen for the same reason. I mean, these are the hypotheses. But yes, but otherwise, in a normal person who does not have a gluten sensitivity, I don't think it would increase or affect colon cancer in any which way.
So, like one of the, we are going to go through the treatment, but before we go to that, there's one question came, but it's regarding the treatment. But before we go to that, another question that I have for you: if someone who's going through issues with their, like if they have problems with their intestines, Dr. Irga and we talk about the intermittent diet, and then I personally see the benefit of that. Do you believe that being on an intermittent diet, like in that case, we don't eat almost for 15, 16, 17 hours, but we do drink water and other stuff. Do you believe that would help if someone is having discomfort with their intestine?
Yeah, so what you're talking about is called intermittent fasting. And intermittent fasting means 16 hours of starvation, 8 hours of eating, or 18 hours of starvation and 6 hours of eating. So how does it help? First, let's talk about the cancer. Cancer cells require more energy than normal cells. So if you're going to be feeding yourself every 2 hours, bulk of that food is going to go to the cancer cell and less food is going to go to your normal cell. So cancer cells are going to get bigger, fatter, and they want to cause more cancer. So intermittent fasting theoretically actually helps fight cancer also, because you are killing the blood supply or the food supply of cancer cells. Cancer cells, if they don't get food every few hours, they won't be able to survive because they need a lot of food. So that's one theory in which intermittent fasting actually helps patients with, it kind of prevents cancers.
So those cells that includes protein, right? That it's kind of killing them, or it's maybe cleaning them when we don't eat.
So for any cell to live, you need a thing called ATP, which comes from mainly from sugars, carbohydrates. It also comes from proteins and fats, but mainly from carbohydrates, where we get our energy from. Cancer cells need more energy than normal cells. So if you don't eat for 16 hours, they don't get that energy. They die. So that is a preventive role of intermittent fasting for cancer. Again, this is theoretical, because as you know, intermittent fasting has been out there only for a few years. We've not studied the long-term effects. That's one. Second, you talked about the bloating and all that stuff and the symptoms people get. Of course, I agree with that. If you starve yourself, you actually reset your body to a state of homeostasis. You kind of go back, and I think that helps. Drinking, of course, you got to hydrate yourself. You keep yourself hydrated. The problem these days is the amount of processed food we eat and the amount of sugars we are eating, which contains high corn syrup, high fructose corn syrup. That is the biggest problem, which kind of hit us in the 60s and the 70s, and we are seeing all the bad effects. Bad effects meaning obesity, diabetes, cancers. I think they're all part of this high fructose corn syrup, and everything has it. You can't go to a grocery store and get a normal ketchup without that. You have to look for it.
Sure. So
if you don't eat, yes, I think that's beneficial, and I think that's also shown to help in weight loss.
It does, and actually, the intermittent diet did come out from the idea of like reducing the aging, which like cancer is probably part of that. It was maybe part of that thought, but it all makes sense altogether as we speak about this more and more. In fact, the other day I had to talk to someone and I had to tell them, look, I mean, if you're having issues, the best is to make those organs that you use less. and then let them rest. But now the way that you are explaining it puts it in a better perspective for them to understand that it's coming from a colorectal surgeon. So, but I'm glad to hear that from you. Now we are going to go to the treatments, and then after that I have a couple other questions.
Of course. So treatment for cancer, for colon cancer per se, is surgery. And you can do this surgery in an open fashion, which was a traditional way we used to do it, or we can do it in a minimally invasive fashion, which is using a laparoscope or a robot. In my practice, more than 95% of both colon and rectal cancer surgeries are being done in a minimally invasive fashion, be it a laparoscope or a robot. And the advantage of that is a lot. Of course, the hospital stay, in the past, it used to be 5-7 days. Now patients are out in 2 to 3 days. Their return to work is quicker. Their pain levels are better. So, and of course, I mean, there have been several studies worldwide on these techniques. And of course, a minimally invasive approach is better in all these parameters for treating cancer. And this is what we normally perform. If your cancer is advanced, meaning it has spread to the lymph nodes or it has gone to other organs, then there is a role of chemotherapy. Radiation is not used for colon cancer. It's typically used for rectal cancer. And that also is dependent on how advanced or how big that rectal cancer is. So bottom line is, if you have an early stage colon or rectal cancer, for the most part, you're not going to be needing chemo, you're not going to be needing radiation. You will be cured, so to speak, by just doing surgery. And that's good. And you'll, of course, need frequent follow-ups. And of course, if it's advanced, then the role of chemo and radiation kind of comes into play.
So, Dr. Vaid, so this is a preventable, treatable, and beatable disease. Although it kills most number of people, I think it's number 2 or number 3. And then it's the third most common. Again, it's preventable, treatable, beatable. Now, United Medical ACO, from the primary care population, we work with so many different patients. As you know, one of the quality metrics is getting people colonoscopy screening. And it's always a challenge to get the patients and get them agree to do this in a timely manner. But I think with these types of educations, I'm hoping that our patients would understand why this is important. Now, especially with the younger people having these types of issues, like one of the questions that I have for a male under 35 years old with first degree relative of cancer, colon cancer, what's the ideal age to start the screening?
All right. So let's talk about it like this. So one is an average risk individual, and the second is a high risk individual. So average risk individual is someone who has no family history, no personal history of colon polyps. In them, we start at the age of 45 and we repeat every 10. Now, high risk individuals are those who have a family history of 1 first degree relative or more than 1 second degree relative. So that belongs to a high risk population. In that, colonoscopy gets started 10 years before the index case or at the age of 40. And it's repeated every 5 years. Meaning, if the index case, meaning their relative who had cancer was diagnosed at the age of 42, we need to start colonoscopy at the age of 32. If they were diagnosed at the age of 40, we need to start at the age of 30. If they were diagnosed at the age of 48, start at 38.
I see.
Yeah, so either you go 10 years before or at the age of 40. You would never go beyond 40, and you got to repeat every 5.
I got it. So 10 years from the relative's age, that would be the time that they will
Or
start.
40 years, yeah.
Mm-hmm.
And whichever is early. So in this, if the relative was 46, then this guy who's 35 needs to do it at 36.
Okay. All right. I'm going to check with Tanner to see if we have any questions that maybe we didn't address. Now, what I'm thinking for our next session for the end of the month, we can gather some questions and we can just do a question answer session.
Absolutely.
And if you would like to add anything after that, we would. Now, I know this has been also tough for providers, physicians, to go through this process, spreading out the patients in certain ways and limited number of cases. And I do believe that's putting a lot of stress on you guys. And I'm hoping that we'll be able to get through this pretty quickly so then we can go back to our normal lives. So anything you would like to say before we close? I mean, I always say this, but right now you are literally in the middle of your office hours and this was your lunch hour, but you are with us. Thank you for that.
Kumal, I don't eat lunch or breakfast, so I am a strong believer of intermittent fasting myself. Cool. So that's great. Yeah, I think you hit the nail on the head. COVID-19, now it's 21. 2 years later, we are still talking about it. Not only talking about it, actually experiencing it every day. And that did, of course, make a dent in our office schedules. And most importantly, it is the amount of screenings which we were not able to do. And there are several studies which came out from Europe that because of delayed screening, patients were presenting at a later stage. They were getting more advanced diseases, more advanced cancers, colostomy bags, and things like that. And as a colorectal surgeon, we absolutely want to prevent that from happening. And the only way we can do that is if we can go back to normalcy and we can go back to our regular screenings and can, in an expeditious way, be able to help our patients.
We are hoping that we'll be able to do that. And as you know, by now, we have our events on a regular basis. This is an add-on event, but tomorrow I'll be back with United Medical ACU updates at 12 noon. And then next week we'll be back on Tuesday first, and then Wednesday with bariatric live event. Dr. Vaid, thank you so much for joining us. We'll see you soon. And